Professor McGorry, I'm very happy to have this interview. You give this interview.
Thank you.
So I have a few questions that will be important for the French organization.
Mm-hmm.
So the first one is, in France, we have child psychiatry for children up to the age of 18,
Mm-hmm.
and adult psychiatry for those over 18. How do you operate?
Well, this is something that we've tried very hard to change in Australia and around the world, actually. And I suppose the way we've done it is by creating particularly enhanced primary care models, like Headspace in Australia and Jigsaw in Ireland and At Ease in the Netherlands. These sorts of models of care which focus on teenagers and young adults. We're bringing them together, so in the age range 12 to 25. So the boundary between the adult system has to move to 25 from 18, because 18 is a terrible time to have this break in care and different cultures of care, because the young people are still growing up. They haven't fully grown up. And also it's the peak period of onset for the major psychiatric disorders, like psychoses, like mood disorders, personality disorders. Everything is happening in this teenage, young adult transition. And if you have a service system with a break in it at 18, it's terrible. Very old-fashioned. So we've made a lot of success with that in about 12 countries now, where we have the primary care platform focused on that age group. And now here in Victoria in Australia, we've been able to shift the boundary of the specialist mental health system up to 25 as well. So that is happening now in this state. So we'll have an alignment of the primary and the secondary and tertiary care systems all around this age group, 12 to 25. And that is the way of the future.
Thank you. How does Headspace work with specialist team? What is the care pathway for a young person experiencing a first episode of psychosis who comes to Headspace?
Okay, so the young people come to Headspace with a problem. You know, they're distressed, they have symptoms of various kinds, or they're struggling in general with life, whether it's with peer relationships or with school or vocational aspects of their lives. Whatever problem they have, we are happy to see them in that Headspace setting. And we know that a proportion of them already have warning signs of psychosis. Maybe 20-30% of them already have sub-threshold psychosis. And sometimes they have fully fledged psychosis when they come in. But we probably need to make that more accessible for the people who are already psychotic as an entry portal, because it's very friendly, it's very youth-friendly, it's safe, and they don't have to get really sick to be able to be assessed and seen. So that's the sort of soft entry way into things. We call it soft entry, because all too often young people with psychosis present late and they are in a very acute, risky situations, and they end up in emergency departments or maybe involved with the police or with a suicide attempt. And we're trying desperately to prevent that by making it very easy for them to seek help in a very non-threatening way. So that's the ideal pathway, but we still have work to do on that front, I think.
For how long youth advisory boards do exist, and do they have a specific contribution according to you?
Okay, so one of the big changes and one of the great success factors in the reforms that we've been involved in has been the involvement of young people in co-designing and guiding what we do. So we have set up youth advisory structures at every level within our headspaces, within our origin services here, in the specialised services. And also we have it involved in our management structures now. We have a director of lived experience in Origin. We also have 2 young people on our board, which is the board overseeing all of the activities at Origin in our services and in our research. We have national advisory groups of young people, including for research. So all of our research is also influenced by young people. So this has been a very positive force. And it contrasts a little bit with what we see in adult psychiatry, where there's a lot of tension between the consumers or the people who have experienced mental illness and the professionals. We don't seem to have that problem with the young people. We're working very effectively in partnership with them in the youth mental health field.
Should we adapt care to the challenges of global warming?
One of the things that's really worrying us is as we are building these youth mental health care systems, the problem is getting worse. The prevalence of mental ill health in young people has risen sharply over the last 15 years in Australia and a number of other countries. So we have to ask the question, what is driving this change. And we've identified a number of mega trends, including climate change, but also unrestrained, unregulated social media. The economic pressures on young people are extreme now. They have trouble buying houses or even renting somewhere to live. They have university fees, which they didn't have in the past. A lot of financial pressures, lots of other changes to the way life is for the young people, and they're not being supported by older generations in a good way. So these mega trends, which include climate change, and it's a classic because it shows the neglect of the older generation for the futures of the younger generation. So we're very concerned about these things, and for that reason we've set up a thing called the Origin Institute here at Origin, which is trying to study and understand these forces and be able to recommend to government policy changes that would protect the mental health of young people.
How Origin's results contribute to the transformation of day-to-day care?
Well, in lots of ways. I mean, our research is all translational. We're trying to improve the quality of care. We are developing new interventions. We are developing new models of care. We're trying to learn more about the nature of some of the illnesses we're treating, particularly eating disorders, which is not very well understood, and the treatments are old-fashioned. So we're trying to modernize and learn as we go in a healthcare learning system. And some great examples are the work of one of my colleagues here, Professor Owen Kalaki, developed a vocational recovery strategy to add to normal clinical care. So we get much better social and functional recoveries for the patients. It went from something like 30-40% recovery rates from first episode psychosis to 80 or 90%. Very dramatic change. And if that was a drug as opposed to just a social intervention, it would have been incredibly, it would have been a blockbuster. And so we try to translate these learnings into the real world of our clinical practice, and also to export these advances in knowledge to other centres and to other parts of the world. And obviously we want to learn from other people in other parts of the world too, who are also creating new knowledge and expertise.
You already answered this question. How is the concept of recovery taken into account?
Well, when I started psychiatry back in the dark ages, the idea of recovery was pretty much antithetical to treating people with schizophrenia. In fact, if you recovered, people tried to say you didn't really have schizophrenia. So it was a massive catch-22, which was completely wrong. And it removed all the hope and optimism from the patients at the very critical time and put them at risk of suicide and demoralization. So recovery is an incredibly important concept. And we have to communicate that to the patients, even if we are very concerned about their prognosis. So the recovery concept has been debated and sort of worked on in different perspectives over the years, but we just believe it's a simple thing. We try to promote the maximum level of functional recovery so people can flourish, they can produce, they can contribute to society and have a meaningful life. And obviously they have to be partners in their own recovery, and they have to help us define what their goals are too. So it's a central concept now in modern psychiatry, which didn't exist when I first started.